So Miss Smith is a 47-year-old female presenting today with intermittent 6 out of 10 sharp right flank pain for the past 3 days. She denied fever, nausea, and vomiting, vaginal discharge, and dysuria, kind of suprapubic pain, or any frank blood in her urine. She has a history of recurrent kidney stones and is followed by nephrology, but she hasn't seen them since March. She states that her pain does feel similar to her past kidney stones, and she currently does take Flomax, 0.4 milligrams, 1 tablet once a day, but she hasn't tried any anti-inflammatories like NSAIDs or Tylenol. She just recovered from COVID last week, where she did not maintain adequate PO intake. She did drink mainly sodas, Dr. Peppers, because that's the only thing she could taste. So she thinks the dehydration is what precipitated this pain. But she didn't twist wrong or hit that right flank pain at all. Her vitals today, her temperature was 98.9, blood pressure 112/78, heart rate 95, respiratory rate 16. Overall, on her physical exam, she was in no acute distress, not toxic with urine. Her lungs sounded clear, auscultation, no wheezes, bronchi or crackles. Her heart was regular rate and rhythm, no murmurs. Her abdomen was non-distended, had normal active bowel sounds, no tenderness of palpation, including suprapubic tenderness. And then she did have right flank pain, tenderness to touch, and mild right CVA tenderness. So, given her symptoms and the time frame and the setting, my differential includes nephrolithiasis, pyelonephritis, and then a muscle strain. So, nephrolithiasis is highest on my differential because she's had a past history of it in the setting of dehydration from COVID, and then she just has that classic colicky flank pain. Pyelo is on my differential because of the flank pain, but it's more unlikely because she lacks other symptoms, nausea, vomiting, fever. And then I added muscle strain because she was tender to palpation on exam, but more unlikely because there was no mechanism of injury. Is there anything else that you would put on your differential?
That is pretty much the main things. One of the other things I would think about is for kind of a non-acute setting that kind of feels like a kidney stone would be something along the lines of the ovaries. So always kind of have that in the background, because you can get ovarian pain either due to cysts or even ovarian mass that actually radiates to the back as well. Ovarian cancer is one of those very sinister kind of situations where it doesn't seem to show up with typical symptoms. So I always kind of keep that in the back of my mind. Obviously that's lower on the differential. The other ones are way more likely, but I always try to kind of think of that as a possibility.
Okay. I'll definitely keep that in mind. So based off of the symptoms that she's had, we went ahead and got a UA on her, and for pertinent results, she had negative leukocytes, negative nitrites, so kind of ruling out the infection there. She did have 2+ blood in her urine. So based on her symptoms, the 2+ blood in her urine, she's likely passing a kidney stone and with her history. So I wanted her to continue the Flomax, 0.4 milligrams. I advised her to increase her fluid intake, water, and to decrease the Dr. Pepper soda intake. We did go ahead and give her a short dose of Norco. She was in pain. For pain relief, she also requested that. I would like to send her for an abdominal CT without to better characterize the stone size, location, any obstruction, hydronephrosis. And then based on those characteristics, if it's too large, she's not passing it, she has frank blood, I would consider sending her back to her nephrologist. I would like to understand more, since this was a classic case of she's had them before, she had a perfect setting that set her up for it. When you would send somebody for CT with radiation versus just empirically treating and observing.
It really depends on the patient's history, so acute versus subacute. If she's presenting in extreme agony and a lot of pain, typically we would go ahead and order a CT scan. She does have a history of stones, so obviously we know it's likely what's going on again. She hasn't been, if she's not been to urology in a long time, and she hasn't had a CT scan in a long time, and now she's presenting with new pain, and having a really hard time with it, I definitely would go ahead and order one. In this setting, she was a little more subacute. I think she had shown up just for a routine follow-up and just happened to be having these symptoms. Hey, by the way, I think I might have a stone going on. I'm having some typical symptoms. In that case, we had discussed with her her options. Definitely gave her that option as far as for workup, but she had decided against it and wanted to go with more conservative treatment instead, which is fine as long as she is non-toxic, passing urine, and not having obvious obstructive symptoms. However, anyone else who we weren't so sure, or they were having more acute symptoms, I would say to go ahead and do that. So you wouldn't go wrong.
Okay.
She had also expressed concern. She'd had a lot of CT scans in the past, so you always have to kind of take that into consideration too. But if the situation warrants it, if you feel like it could be life-threatening, without getting the scan, then sometimes you just have to go with it. So there's a lot of different things to have to think about.
Okay. Well, thank you.
You're welcome.